each patient you have different relation, let's say, and mostly your GBM patient, glioblastoma, that you establish a relation, long relation, and you are with this patient in every decision. They call you, they ask you, and in the last 2 years in their life, they will call you for any alternative treatment, and you will try to guide them. And so you are in the process, and at the end, this ending all this effort from your side and their side ended unfortunately with patient dying. And this, you feel the failure, of course, because you want to save them, you want to improve their outcome, you want to promise them that they will be at the wedding of their daughter, and you are involved, and they are young patient. So you feel the failure, yes, unfortunately, or hope, or I will say powerless, let's say it this way.
I would piggyback on that as well. It's making sure that we engage the patient and that they and their family feel like they're part of the team, understand their goals of care. And I think the responsibility is to guide their active care when it's appropriate, as many of the other team members have said, but also to guide their transition to supportive care as they near their end of life for a patient who is not going to be cured of their cancer. I think that that's an important role that we have, and that the patients look to us, and their families, frankly, look to us to provide. And it's a huge responsibility, but it's also a huge honor to play that role and to help the family and the patient transition through that process.
I believe as our outcome from surgical treatment for these patients are exceptional, and many people can say that. And we had patient living 3 years after GBM resection. So my word failure is not failure in our surgical performance or our surgical treatment. Excellent job, but failure overall in human being relation. And every time the patient, they come to you and they have a hopes. They say, I'm going to live. I know I will beat that. And it's not true. So it's very difficult relation.
I think I want to expand that almost into sort of other realms, because this is a common thing that I think we deal with in neurosciences, in neurology, in neurosurgery. And it goes beyond just, someone who has a bad diagnosis of a malignant brain cancer, but let's say someone who's had a devastating stroke and now has to live with their deficit for the rest of their life, or someone with a ruptured aneurysm that, you're toiling away, you're coming in night after night doing procedures to try and get them through, and ultimately they don't have a good outcome. Maybe they've had a month in the ICU, and at the end the decision is made to, either something happens or to let them pass, knowing that they're not going to make it through. This feeling of like we failed, not necessarily as people or as doctors, but just as in our ability as humans to get this patient through that problem. And I think that it's something that we see very commonly in our field. And I think more so than a lot of other fields, because we often deal with potentially devastating illnesses. And I think it's an important part of our training and how we're brought through as we start our practices and dealing with patients of finding ways to sort of cope with that and live with it as part of your everyday life. That, it's a routine discussion on my end to talk a family through what it means when their family member has had a ruptured aneurysm, that, their overall survival is very tenuous, and we're going to do everything we can, but it may not turn out well. And having that discussion, day after day. But I completely agree with what Dr. Lakator said. I mean, I see that as an honor and a privilege of